important clinical based questions in the cardiology are the following. So we have a 68-year-old male patient with a history of chronic obstructive pulmonary disease. He presents to the emergency department with the palpitations, dizziness, shortness of breath. His heart rate is 110 beats per minute and rhythm is irregular. The auscultation reveals multiple rapid heartbeats. The ECG shows irregular RR interval and P waves are present, but they appear with varying morphology. What is the most likely diagnosis? The options are ventricular tachycardia, multifocal atrial tachycardia, atrial fibrillation, and then the sinus tachycardia. So you take the ECG of ventricular tachycardia, you will not have the P waves at all, right? But the question says the P waves are there, but they are of variable morphology. So it is not suggestive of ventricular tachycardia, because in ventricular tachycardia you will have broad QRS complexes with absent P wave. Then you take the atrial fibrillation. I'll come to the second option in the last. You take in atrial fibrillation. In atrial fibrillation also you don't have the P wave. Rather than that, you have the presence of the fibrillatory waves. Right? Rather than that, you have the presence of the fibrillatory waves. And how will be the RR interval in patients with the atrial fibrillation? Yes, it will be irregular RR interval, but P waves are present. This is one point which is going against your atrial fibrillation, because in atrial fibrillation what you will have is the fibrillatory waves but absent P waves. And you take in case of the sinus tachycardia. In case of sinus tachycardia, the RR interval will be absolutely regular. Okay, so you will have the sinus P wave, that means the normal P wave, tachycardia will be there, and the RR interval will be regular. So these are the points suggestive of the sinus tachycardia. Then the answer here is the multifocal atrial tachycardia. Why? Because multifocal atrial tachycardia is one important form of arrhythmia which is very common in patients with the chronic obstructive pulmonary disease, right? And in case of multifocal atrial tachycardia, you will have the different P wave morphologies, and you also have a criteria for that. There should be more than or equal to 3 different P waves, right? There will be more than or equal to 3 different P wave morphologies, right? And at the same time, the heart rate, it should be more than 100 per minute. The heart rate, it should be more than 100 per minute. That is what you will observe in patients with the MAT, that is multifocal atrial tachycardia, which is very common in patients who are having the chronic obstructive pulmonary disease, right? And in patients with this MAT, like, what is the treatment? See, if it is secondary to COPD, where we cannot give beta blockers, in these patients with MAT, the preferable treatment will be non-dihydropyridine calcium channel blockers, and examples include diltiazem and verapamil. And if this multifocal atrial tachycardia is not due to COPD, then the preferable drugs will be the beta blockers, right? The preferable drug will be beta blockers in case of MAT if it is not due to the COPD. So this question, the answer is multifocal atrial tachycardia, right? And this multifocal atrial tachycardia, heart rate should definitely be more than 100 beats per minute. There should be irregular RR interval, and the P wave morphologies will be completely variable, and more than or equal to 3 different P wave morphologies should be there, and presentation will be in the form of the palpitations, right? Next question. A 40-year-old male with history of recurrent episodes of the atrial fibrillation is prescribed Quinidine, an antiarrhythmic medication. Which of the following statements regarding Quinidine and its features are true? Quinidine is a class 1B antiarrhythmic drug. It primarily acts by blocking the sodium channels and thereby prolonging the action potential duration. Third, Quinidine is known to cause the shortening of the QT interval on the ECG. Fourth, the most common adverse effects of the Quinidine is hypokalemia, right? Now, first point, yes, Quinidine is definitely an antiarrhythmic drug, but this Quinidine, it blocks the sodium channel. It's a class 1 antiarrhythmic drug, but it is not class 1B, it is class 1A antiarrhythmic drug, right? And what is the mechanism of action? The Quinidine, it blocks the sodium channels, thereby it slows down the rate of depolarization during the action potential. So it primarily blocks the sodium channels, thereby prolonging the action potential duration. Why? Because it is blocking the entry of the sodium channels, and it is very much required in the treatment of the arrhythmias and as well as management of the arrhythmias. And the quinidine is known to cause shortening of the QT interval. This is the wrong statement. Now this particular quinidine, it is prolonging the depolarization, so thereby what will happen to your QT interval? There will be QT prolongation with the quinidine. You will not have short QT interval, you will have a long QT interval. Then the most common adverse effect of quinidine is the hypokalemia. That is a wrong statement. So most common adverse effect of quinidine, it is not hypokalemia, right? This quinidine can cause various side effects, including gastrointestinal disturbances, and as well as quinidine is mainly associated with the development of an important adverse effect that is called synchronism, right? That is what is called synchronism. What is the characteristic features of synchronism? The characteristic features of the synchronism will be, number one, tinnitus, then hearing loss, and then visual disturbances, right? So these are the features of the synchronism. And another important potential adverse effects will be the long QT interval. And this quinidine, it is obtained from a plant product. And what is this plant product? This is known as the cinchona bark. From the cinchona bark, this quinidine, it is being obtained, right? And this quinidine inhibits which particular sodium current? It will inhibit fast inward sodium current, right? It will inhibit the fast inward sodium current. And if you take the adverse effects of this quinidine, it will cause the QT prolongation, it will cause dizziness, fatigue, and as well as headache. There can be development of the skin rash, weakness and tremors, and there will also be the vision disturbances, right? Whereas you take the electrolyte abnormalities like hypokalemia and as well as hypomagnesemia. Hypokalemia and hypomagnesemia is rare, right? And if it is given at higher doses, it can cause synchronism, which will lead to tinnitus, which is an ear problem, which will lead to diplopia, which is an eye problem, and this will also cause the excitation of the central nervous system, right? So this is about the quinidine and as well as its adverse effects. Next question. A 25-year-old pregnant woman presents to the obstetric clinic for a prenatal checkup. She has history of bipolar disorders. On prenatal ultrasound, the fetus exhibits cardiac abnormalities, including an inferiorly displaced tricuspid valve, tricuspid regurgitation, and a small right ventricle and WPW syndrome. Now, which of the following drugs is most likely to be responsible for the following finding? The options are lithium, valproate, captopril, then the carbamazepine. So, this is in case of 25-year-old pregnant women having bipolar disorders. There is distal displacement of the tricuspid valve. So all these points, and one more important point is WPW syndrome is present. So all these points, they are suggestive of the Epstein's anomaly. So in Epstein's, you will have distal displacement of the tricuspid valve, and there will be atrialization of the right ventricle, and there will be small right ventricle. And the ECG will show in patients with Epstein's, there is increased chances of the presence of an accessory pathway in case of Epstein's, right? And presence of the accessory pathways in Epstein's, it is nothing but the WPW syndrome. And what is the drug which is associated with the development of Epstein's anomaly is, that is the lithium. So lithium, it is very much important, known for the congenital heart disease, that is Epstein's anomaly, right? So this Epstein's anomaly occurs mainly when the patient takes this lithium in the first trimester of the pregnancy, right? Where there will be distal displacement of the tricuspid valve, and there will also be tricuspid regurgitation as well, right? Whereas you take this valproate. Valproate is an anti-epileptic drug that is being associated with increased risk of neural tube defects, right? Increased risk of neural tube defects. Whereas you take this captopril. Captopril is an ACE inhibitor. What this captopril is associated with? The captopril, when it is taken in pregnancy, it is associated with renal agenesis, right, associated with renal agenesis. That is the reason why these ACE inhibitors are absolutely contraindicated in pregnancy, because it can cause renal agenesis in the fetus. Whereas you take this carbamazepine. See, carbamazepine, it is more commonly associated with the neural tube defects during the pregnancy, right? So it is the lithium which is associated with the development of the Epstein's anomaly and increased risk of the pre-excitation syndromes, that is the WPW syndrome, right? Moving on to the next question. We have a 3-week-old infant is brought to the clinic due to bluish discoloration of lips, skin and nail beds. The baby tires quickly during the feed and often appears fatigued. On examination, the infant is visibly cyanotic, and cardiac auscultation reveals the single sound, first heart sound, and single S2 as well, and a systolic ejection murmur. There is cardiomegaly on the chest X-ray. What do you think is the diagnosis? The options are tetralogy of Fallot, patent ductus arteriosus, tricuspid atresia, and as well as coarctation of aorta. See, first of all, what type of congenital heart disease is this? It is a cyanotic congenital heart diseases, right? So cyanotic congenital heart disease, like we have 5 T's, that is tetralogy of Fallot, then tricuspid atresia, transposition of the great arteries, truncus arteriosus, then total anomalous pulmonary venous connection. So these are the 5 T's which are the cyanotic congenital heart diseases. Now, so this patent ductus arteriosus, coarctation of aorta is ruled out. Yes, even in patent ductus arteriosus also, there can be development of cyanosis whenever there is development of Eisenmengers, right? So when there is a scenario of development of Eisenmengers, then you have this, the patent ductus arteriosus. But whenever there is Eisenmengers, you know, there will be development of pulmonary hypertension and there will be loud P2 as well, right? Now, so the probability is option A and as well as the option C. But you take the presence of single loud S1, this will rule out the tetralogy of Fallot, right? So because in case of the tetralogy of Fallot, like what all will be the problems? There will be ventricular septal defect, there will be right ventricular hypertrophy, subpulmonic stenosis, and overriding of aorta. You don't have any abnormality in the first heart sound in case of the tetralogy of Fallot. So this one important point, the presence of the single loud S1 will completely rule out this tetralogy of Fallot. So whatever the features which has been given, they are suggestive of the tricuspid atresia. So tricuspid atresia is that where the tricuspid valve is absent or the tricuspid valve is poorly developed, right? And this tricuspid atresia results in the absence of right atrioventricular connection, right? Because the tricuspid valve is absent, there is absence of the right atrioventricular connection. So in tricuspid atresia, a single functional ventricle pumps the blood to systemic circulation, resulting in the early neonatal cyanosis. So whatever the clinical findings like central cyanosis, chest X-ray showing cardiomegaly, presence of the single loud S1 and single S2, right? What is that single S2 that you will have in case of the tricuspid atresia? That will be A2. The P2 component will be absent, right? And the next is the ejection systolic murmur. So the presence of a systolic ejection murmur which can be associated with turbulent blood flow through the malformed tricuspid valve. So all these are the points suggestive of the tricuspid atresia, right? So it is not tetralogy of Fallot because in tetralogy of Fallot you will not have a single loud S1. It is not patent ductus arteriosus because it is acyanotic congenital heart disease. And in coarctation of aorta, the presentation will not be in the following manner whichever has been described. Okay, so because in patent ductus arteriosus, like what is the murmur that you will have? A continuous murmur. Even in case of the coarctation of aorta, what is the murmur that you will have? You will have a continuous murmur. And in case of coarctation of aorta, what is that you will have is you will have differential in the pulse. If you take the coarctation is present distal to the left subclavian artery, then there will be radiofemoral delay. Whereas if the coarctation is present proximal to the left subclavian artery, then it will be radioradial delay. So it all depends upon where exactly the coarctation is being present. Okay, so the answer here is the tricuspid atresia. And in case of tricuspid atresia, it is the surgical treatment which is required after the minimal medical management. Okay, so moving on. So this question answer is the tricuspid atresia, right? And what will happen to your second heart sound P2 in case of tricuspid atresia? The P2, it will be soft or it may be absent. Whatever one particular sound that will be there is only A2 will be there in case of tricuspid atresia, right? Moving on to the next question. So we have a 10-year-old boy is admitted to the hospital for the pneumonia. Further evaluation revealed the presence of the atrial septal defect. The parents deny any prior complaints such as shortness of breath and as well as the chest pain. And there is no family history of heart disease except for the ischemic heart disease in the grandfather. Which of the following is incorrect regarding the atrial septal defect? The options are pulmonary plethora leading to pulmonary artery hypertension, murmur presents early in the course of the disease, flow murmur is present leading to the mid-diastolic murmur, shunt murmur is absent. So the patient is having atrial septal defect. So thereby that will result in shunting of the blood from the left atrium to the right atrium, and that will result in the pulmonary plethora, right? Where there is increased flow of blood across the pulmonary artery resulting in pulmonary arterial hypertension, right? Next, murmur presents early in the course of the disease. That is a wrong statement, right? In atrial septal defect, murmur does not present early in the course of the disease. It presents in the later stage, right? It presents in the later stage, and that too, it is the flow murmur, right? And that too, it is a flow murmur. And flow murmur is present leading to a mid-diastolic murmur. That is a correct statement here, right? So why is this mid-diastolic murmur or flow murmur? Because in atrial septal defect, right atrium is receiving the blood from superior vena cava, inferior vena cava, and right atrium is also receiving the blood from left atrium as well, resulting in the development of increased flow of blood from right atrium to right ventricle. So there will be functional tricuspid stenosis resulting in mid-diastolic murmur, and the shunt murmur is absent. In case of ASD, the movement of the blood from left atrium to right atrium will not give rise to any murmur. Whereas in VSD, there will be a pansystolic murmur when the blood is moving from the left ventricle to the right ventricle. That shunt murmur is absent in patients with the atrial septal defect. What is that you will have is you will have a flow murmur, and that too in the later stages of atrial septal defect. So murmur present early in the course of the disease, it is the wrong statement, right? Moving on to the next question. And in patients with atrial septal defect, what are the other features? In case of the atrial septal defect, on auscultation, you will have the presence of a wide fixed split, right? The presence of the wide fixed split, right? And next important is when you do an ECG, right? When you do an ECG in patients with the atrial septal defect, there can be presence of an incomplete right bundle branch block, right? There can be presence of incomplete right bundle branch block. So that is about the question related to ASD. Now, moving on to the next question. So we have a 66-year-old male was brought to the emergency department with complaints of dyspnea on exertion for 1 day. On examination, there is presence of heaving apex beat and carotid thrill was present. Auscultatory findings showed ejection systolic murmur, the intensity peak in the middle and then downfall, and the presence of the S4 and single S2. The doctor advised transthoracic echocardiography. Which of the following is incorrect transthoracic echocardiographic finding in this patient? So if you take this entire clinical picture, 66-year-old male presenting with dyspnea on exertion, the heaving type of apex beat and carotid thrill is being present. Auscultation showed ejection systolic murmur, right, which is peaking in the middle, and there is presence of S4 and single S2. So all these points, they are suggestive of the aortic stenosis. When you do a transthoracic echocardiography in case of the aortic stenosis, it will show you the size of reduced orifice. Actually, the normal aortic valve area, this is around 3 to 4 centimeters square, right? If the aortic valve area is less than 2 centimeters square, this is suggestive of the aortic stenosis. Aortic valve area less than 2 centimeters square is suggestive of the aortic stenosis. That is, and if the aortic valve area, if it is 1.5 to 2 centimeters square, this is suggestive of mild aortic stenosis. And if the aortic valve area, if it is around 1 to 1.5, then it is suggestive of moderate aortic stenosis. And if the valve area is less than 1 centimeter square, this is suggestive of the severe aortic stenosis. right? This is suggestive of the severe aortic stenosis. Okay, so now this will show, the transthoracic echocardiography will show you the size of the reduced orifice. That is a correct statement, or that is a true statement. The ejection velocity is more than 4 meters per second. Yes, that is very much suggestive of the aortic stenosis, and that can be made out in the 2D echo. And transvalvular gradient is more than 40 millimeters of mercury. See, if you observe the gradient between the left ventricle and aorta, it should be around 5 millimeters of mercury. To call it as aortic stenosis, the gradient between the left ventricle and as well as the aorta, it should be more than 10 millimeters of mercury. And if the gradient is more than 40 millimeters of mercury, it is very much suggestive of the severe aortic stenosis. And it shows the shape of the reduced orifice. No, the 2D echo will not show you the shape of the reduced orifice. It will just tell you the size of the reduced orifice. Okay, so that is what we are doing the 2D echo for. That is mainly to show the size of the reduced orifice, not the shape of the reduced orifice. So the incorrect statement about transthoracic echocardiography in patients with the aortic stenosis is it shows the shape of the reduced orifice. It is the wrong statement. Coming on to the next question. So, a 6-month-old infant is brought to the pediatric cardiology clinic for evaluation of the heart murmur noted by the parents. Upon examination, the physician identifies the ventricular septal defect. Further assessment is required to determine the specific type of VSD present in the infant. So, which of the following types of the VSD is most common? Perimembranous, muscular, supracrystal, and as well as the sinus venosus type. So, the most common type of VSD is the perimembranous type of VSD. Right, and this perimembranous type of VSD, it is also known as, right, it is also known as membranous or subaortic type. Right, membranous or subaortic type, and this type of VSD is located adjacent to the membranous septum, and it is typically found in the membranous portion of the ventricular septum, right? And this membranous type of the VSD, this will account for majority of the VSD, and this will account for nearly around 70 to 80% of all the VSDs. Right, this will account for 70 to 80% of all the VSDs. Then next one is the muscular VSDs. The muscular VSDs, they are also known as trabecular VSDs. They are also known as mid-muscular VSDs. So this muscular VSDs, which is trabecular or mid-muscular VSDs, they are located within the muscular portion of the ventricular septum. Right, they are present in the muscular portion of the ventricular septum. While they are a common type of VSD, they are not most prevalent. So which is more prevalent? That is the perimembranous. The other one is the supracrystal. Supracrystal VSD is also known as conal VSD or outlet VSD, and they are situated above the level of the aortic valve, and they are less common than the perimembranous VSDs. Then we have the sinus venosus. The sinus venosus defects are the type of the atrial septal defect, but not the VSDs. So sinus venosus is, it is a form of ASD but not the VSD, and they involve the atrial septum. The sinus venosus type of ASD, they involve the atrial septum, specifically the area where the superior or inferior vena cava enters the right atrium. So sinus venosus defect are a type of the ASD, right? So this is about the question related to the atrial septal defect. Moving on to the next question. So we have a 56-year-old male presents to the emergency department with sudden increase in blood pressure and severe headache. On physical examination, you notice bilateral retinal hemorrhage and proteinuria. The patient also complains of confusion and dizziness. The image depicts the pathological specimen collected for further analysis. What condition should be considered in this patient based on the clinical presentation? So the patient is having sudden increase in blood pressure, and there is severe headache, and there is bilateral retinal hemorrhages, and as well as the proteinuria as well, and the patient is confused and having dizziness. And this is the pathophysiology specimen for further analysis. So the patient is having hypertension, the patient is having bilateral retinal hemorrhage, proteinuria and confusion. So along with hypertension, eye is affected, kidneys are affected, and as well as even the brain is also affected, right? So these are the points to tell you that the individual has developed the malignant hypertension. See, if it is essential hypertension, you don't have ophthalmic involvement, you don't have kidney involvement, and you don't have CNS involvement. If it is hypertensive encephalopathy, you will have only CNS involvement, you don't have this retinal involvement, and you don't have the renal involvement in the form of proteinuria. And atherosclerosis, it is one of the risk factors for the development of the hypertension. But in case of atherosclerosis, you will not have, along with hypertension, you will not have this end organ damage, only in case of the picture suggestive of the atherosclerosis. So there is an end organ damage here. There is retinal hemorrhage. This retinal hemorrhage, it is suggestive of the retinopathy. There is proteinuria, which means there is hypertensive nephropathy. There is also CNS manifestations that is suggestive of the hypertensive encephalopathy. So all these three together, we tell it as the malignant hypertension, right? And pathologically, this syndrome is associated with diffuse necrotizing vasculitis, right? So what is that you are able to make out in this pathological specimen is the fibrin deposition. The fibrin deposition in the arteriolar wall, and it is also associated with diffuse necrotizing vasculitis. So this will be the pathological specimen that you will have in patients with the malignant hypertension. So why is it not the essential hypertension? It typically does not present with sudden onset severe symptoms. Retinal hemorrhages, proteinuria, confusion, they are not the features of essential hypertension, right? So that is the reason why the answer is the malignant hypertension in these patients. Moving on to the next question. We have a 58-year-old male presents to the clinic for a routine follow-up. He has history of hypertension and type 2 diabetes mellitus for the past 10 years. His blood pressure is currently 150/90 and his fasting blood glucose is 160 milligrams per deciliter. On further examination, his serum creatinine level is 1.5 milligram per deciliter and estimated GFR of 45 ml per minute per 1.73 meter square. Which of the following is most appropriate target blood pressure for this patient? So the options are less than 140/90, less than 130/80, less than 140/80, less than 130/75. So the patient is diabetic. Blood pressure is 150/90. And the GFR is reduced to less than 45. So it is the feature suggestive of the diabetic nephropathy. It's a feature suggestive of the diabetic nephropathy. So what is the target blood pressure in case of the diabetic nephropathy is less than 130/80. So this is the guidelines from the American Diabetic Association, or this is the guidelines from the American Heart Association. So the point suggestive of diabetic nephropathy is the GFR which is being reduced. The estimated GFR, normal individual, it should be more than 90. So it is like around 90 to 120 ml per minute per 1.73 meter square, right? And the creatinine, it will be elevated in patients with the diabetic nephropathy. So whenever there is diabetic nephropathy, the blood pressure should be less than 130/80 strictly. If you don't maintain the blood pressure as less than 130/80, then there is progression of the diabetic nephropathy to a stage of the end stage renal failure, right? And in cases of, like in the previous question, we were discussing about the malignant hypertension. Okay, so in case of the malignant hypertension, how much blood pressure should be reduced? So the blood pressure should be reduced by 20 to 25% over 2 hours. Right? The blood pressure should be reduced by 20 to 24% over 2 hours. Okay. So the answer in this particular question is less than 130/80. So moving on to the next question. So we have a 65-year-old male patient with history of hypertension presents to the emergency department with sudden onset right-sided weakness and slurred speech within 4 hours. The imaging confirms an ischemic stroke. The patient's blood pressure upon arrival is 200/120 millimeters of mercury. What is the appropriate management strategy for this patient based on the current guidelines? The options are, so okay, first of all, what is the problem here? The onset of right-sided weakness and as well as slurred speech within 4 hours. Blood pressure is 200/120 and imaging shows that it is ischemic stroke. So within 4 hours the patient has presented. So he is an ideal candidate for a thrombolytic therapy with the tissue plasminogen activator. But how much should be the blood pressure whenever you want to start thrombolysis in a patient with the ischemic stroke? You see the options. Immediately initiate the thrombolysis regardless of the blood pressure level? No. It is incorrect statement. When you have a blood pressure of around 200, if you start thrombolysis, there is chance of the ischemic stroke turning into a hemorrhagic stroke. There can be rupture of the blood vessels. No. So first option incorrect. Lower the blood pressure with IV nicardipine to less than 185 by 110 before considering the thrombolysis. This is the correct statement. So you need to reduce the blood pressure to less than 185 by 110. Then you can go ahead with the thrombolysis in patients with the ischemic stroke, right? And you take the third option. So lowering the blood pressure to less than 160 by 90 before considering thrombolysis is not required. You can reduce the blood pressure to less than 185 by 110 and then you can go ahead with the thrombolysis, okay? And initiate thrombolysis only if the blood pressure is within the range of 130 to 140. See, this blood pressure is required in cases of the ICH, okay? So in patients or in cases of intracerebral hemorrhage, right, there you require the blood pressure of nearly around 130 to 140 millimeters of mercury, but not for thrombolytic therapy in case of the ischemic stroke, okay? So you say in case of ischemic stroke, the target blood pressure before starting thrombolysis will be like less than 185 by 110 millimeters of mercury, and to lower the blood pressure you need to give the IV nicardipine, right? And if the blood pressure is around 220 by 130 is not a candidate for thrombolytic therapy. And next is the intracerebral hemorrhage. If the patient is having the intracerebral hemorrhage, the blood pressure has to be reduced to around 130 to 140 millimeters of mercury, okay? So these are some of the important clinical based questions in the cardiology. Thank you very much.